Good afternoon. These guys are doing a way better job than we did moderating, keeping us on track. So thank you, thank you, Venki, for the invitation to come back. We just came from Colorado. Believe it or not, my kid made me learn how to ski, and which is amazing. So coming back to Phoenix now is even better in the warm. So Venki calls it the stupid femoral artery. He also calls it the stupid effing artery. I was his fellow, I remember. And it's because of the pressure and the torque and the forces that are on the superficial femoral artery that I think it makes it very, very challenging. So typically, this is the kind of disease we see where there's a long SFA occlusion. And of course, now we have a whole ever-growing list of different devices that we can use to treat it. But really, the question that has not changed, for me anyway, I've been doing this for almost 20 years, is that what's really a durable treatment? I feel like we still argue and debate on durability. So I took a step back looking at a few years ago, I think, looking at really what's going on. And we talked a little bit about this at dinner last night. Dr. Zarens brought it up. We had a nice heated discussion about that as well. And I think it's time to go back to being a real doctor. So what I mean by that is it's a systemic inflammatory disease, atherosclerosis. It affects multiple parts of the body. And I think us having a little conversation with our patients about stop smoking, watch your cholesterol, take care of your diabetes, come back for your visits, check your pressure, goes a long way. And I don't think that we always do that enough, and I think that's important to do. So my task, no pun intended, is to talk about the 4 tasks, task A, B, C, and D, and to say, okay, so when you have these lesions, what should you be doing? So A and D are the easy ones because it's basically, A is pretty simple. It's less than 10 centimeters of stenosis or 5 centimeters of occlusion, usually all in the SFA. D is, again, relatively simple. It's a CTO. It's a chronic total occlusion, usually of the SFA more than 20 centimeters. Or you can go down into the pops and you can go into the tibials, and that can be your task D. It's the B and C, I think, that can be a little bit hairy. So I'm going to say at this point in my life that the most important thing that I can do for my patients really is the cornerstone of therapy. It doesn't matter what device I do. Being able to do good medical therapy as a vascular surgeon, which is what I have learned from my coronary colleagues, is very, very important, because I think that's the thing that sometimes we miss. And having that conversation with them over and over again about stopping the smoking, about taking better care of themselves. I think the other piece is the surveillance. We chalk it off as non-compliance, they're not coming back, they're very difficult patients. Well, we need to scare the shit out of them if necessary, have them come back, do the surveillance, keep an eye on them. And I think a lot of this then can be reduced. And then, of course, there's devices. You're going to pick which device you're good at, your experience. You're obviously not going to be able to do every single device that's out there, but then pick your poison, learn it well, master it, and basically stick to it. So I'm going to go a little bit into Voyager. I think one of the reasons Voyager was successful, this is frankly the only good study that looked at outcomes based on medical therapy. All of these patients were very well medically optimized. And then, of course, they add in the Xarelto, which, of course, no longer exists now because the company decided that it's going to go generic, and Xarelto is available, but as you know, there's no reps, and you can't get the service that you used to get before. But it is the only study with good medical management that showed you can reduce acute limb ischemia and major amputation much more than any device that we've shown today or that we've done. So it reduced not only that, but it reduced the secondary outcomes of unplanned index limb revascularization or hospitalization for a coronary or a peripheral cause down the road. And I think that is huge. So if you were to take one thing away from that, I think medical therapy with good follow-up, whether it's rivaroxaban, aspirin, DAPT, whatever it is, and just keep talking to your patient to stop smoking. So I'll change lanes here a little bit, and I'll talk about my green run, which used to be one of my favorite runs, except now I'm a blue skier, so now I moved up the food chain. But if you're doing a task A, honestly, I think you can get away with just about anything. I think it's obviously you want to look at your lesion. We're not talking about the clinical aspect of it. We're not talking about Rutherford. We're just talking about anatomical task A lesions. I think any one of them do well. You'll have good 90% two-year primary patency, 100% secondary patency. And if you're not, then frankly, you're doing something wrong. It's definitely endo only for task A. Most people would agree. And then I'm going to go to task D, which is my double black diamond, which I will never do. I'm going to tell you that right now. But I think these are really, really the challenging cases. I think as a vascular surgeon, I think mostly of these cases is a vein bypass, if it allows it. Remember, a lot of our patients are pretty sick. I love the PTAB idea. I've been doing more and more PTAB. Hopefully, insurance continues to cover it. And then for patients, depending on the situation, remember, we're just talking anatomically TASC D, the combos. I don't think you're going to get away with just doing a simple angioplasty. You're probably going to want to do a stent, or you're going to want a DCB, or you're going to want a DES, maybe an atherectomy with a DES. And then as a surgeon, I get the advantage of doing a hybrid where maybe I do a common femoral end dart and a SFA nub, and then I go in and do a hybrid procedure and do something. But I think the TASC Ds are the more complicated ones. They've had multiple interventions done. And so the B and C are kind of where I am in skiing right now, and I'm sort of doing some greens, mostly blues. And so B and C is that to me. I think, again, it's a little bit of a combo. I don't think you're going to get away with just one treatment, whether it's shockwave lithotripsy or just atherectomy. You're probably going to want to treat it. I do tend to be more of a spot stenter. And so it really depends on what your experience is and how you do it. But I don't think there's a wrong answer to endovascular first for B and C. And then if it doesn't fail, or they've had multiple interventions, or you think they're a better candidate for a vein bypass or a PTFE bypass or a PTAB, I think you can get them decent results. I didn't go into a lot of the data with it because it's been presented all morning. I didn't want to overload you with data. But the primary patency in a TASC B or C, it really isn't the best, depending on the clinical condition, depending on the Rutherford, depending on CLTI, or just claudication. It's anywhere between 50 and 80%. So I think, to wrap it up, the best options, honestly, as going back to being a real doctor, talk to your patients, talk to them about medical therapy. You know, the diet, cholesterol, if they don't like statin, look at the other alternatives, managing their hypertension. Anticoagulation, I think, is a big one with best medical therapy, whether it's DAPT. I'm not big of a Plavix user anymore, given the rivaroxaban and aspirin results that we've seen. And then really the surveillance. If there's one thing I think that I'm learning is really trying to keep them back on track, using AI, using your electronic medical record to get your patients back in for that surveillance, keep the non-invasive arterial studies. You know, the case that was just presented with the above knee amputation, that patient, if it was really surveyed, shouldn't have come to the point where now he's got one vessel runoff on that opposite side 3 years after. Like, that doesn't make sense. It's an easier fix, I think, for us to just take ownership of those patients and keep an eye on them. So thank you very much for the minute to stay.